Next, I have the privilege to introduce Dr. Muzaffar. She completed her MD here in the University of Missouri, Columbia, and she got her MPH at Johns Hopkins. And she also has some very prestigious fellowships in surgery and clinical care. So she came to the medical director position at the state HealthNet, or the Medicaid agency, with good local, state, and national public health experiences that really has an excellent advocate for us in this very bureaucratic program that does good things. So with no further ado, and before I get too off track, I welcome Dr. Muzaffar to share what they have been doing in the state Medicaid office in relation to this issue.
Good morning, everybody. Please let me know if I trail off, because I do sometimes, and if you can't hear me, speak up. I want to thank the organizers for the opportunity to be here this morning to talk about the work that we're doing around this issue. We've been really fortunate to have some really strong partners in the state that we've been able to collaborate with, so we're very appreciative of that. As Deb mentioned, my background started out in surgery and then ended up in the public health area, although I did the public health during medical school, and trying to figure out how do these things fit together. And the thing that attracted me to the Medicaid program was that the director at the time when I started really emphasized his desire to have a public health and population health level impact. So be a payer and pay for the services and provide the services, but you have a population of 900,000 to 1 million people that you can directly impact. So how can we do that? So that was what attracted me to the Medicaid program, and that vision really informs, in terms of the research and innovation that we try to do, that informs the work that we do in that area. And as we think about the different programs that we put together, whether it's at sort of that systems infrastructure level or at the individual person services that you deliver level, we're really thinking about how that impacts, primary, secondary, tertiary prevention. So that's sort of the framework that we're working with. When we talk about overweight and obesity, we had started looking at what we are doing and what we could potentially do around 2011, 2012. And so, again, looking at the systems level and the infrastructure level and the service level, thinking through the different interventions we had in place and what we could put in place. And so some of you may be familiar with our primary care and CMHC health home programs. So there is an infrastructure built there where we can directly impact and intervene when we think about overweight and obesity. And then the services level, we started thinking about what do we do on the surgical side intervention-wise, and what do we do on the medical side intervention-wise. So the first thing we did was we updated our bariatric surgery criteria and tried to advance those from where we were. And then the next thing we did is we started looking at the medical side. So what can we do there and what are we not doing there? And that's when we started looking at the USPSTF recommendations around intensive behavioral therapy and medical nutritional therapy. And then we were also looking at, in conjunction with that, the DPP program more recently. And so we've been doing some work around that as well. And, of course, our goals are the same as everyone else's. You want to decrease morbidity, mortality. You want to enhance quality of life and wellness. And you want to, through those efforts, have an impact on the costs in the healthcare system. And those are the things that all of those things that we focus on. And one, the important thing for us is we want to impact quality as well as cost. We don't want to impact cost by itself. So, and that's sort of a driving principle for us. And, as we went through these efforts, they sort of coalesced with what was happening with the Children's Services Commission. We were sort of working on those things in parallel, and through the leadership of Denise and Sarah, we were able to sort of come together, and it was a great partnership. And again, we've been pretty fortunate in being able to do that. And so that's sort of where we are today, talking about how you translate, at least for the Medicaid program, the research and the evidence into policy and programs. So I'm just going to walk through, in this context, how we sort of think about these things as we, in general, put together a program. So for the Medicaid population in Missouri, you're talking about roughly 900,000 participants. About 3/4 of them are now in managed care, and 1/4 are fee-for-service. And those are usually the age-blind and disabled folks. Of the Medicaid population in Missouri, about 1/3 are adults and 2/3 are children. When you think about obesity rates and trying to measure those in a Medicaid program, our data is claims-driven. So if it's not on a claim, we don't know that it happened. You know, if somebody doesn't send a claim in or bill for a service that they provided, we can't count that. So how do we get a better proxy for those rates in our Medicaid population? And so I mentioned that Health Home program. With the Health Home program, we do collect patient-specific information that goes to through an existing sort of collaborative relationship. And so we can sort of take a look at that and figure out what our rates look like. And this is a concentrated population in the Health Home program, so these rates are most likely higher than the general Medicaid population in Missouri. But when we started the Health Home program, we started in 2012, and when we looked at the data in 2013, about 74% of the population had a BMI greater than 25. We had eligibility change where we were lucky to be able to make obesity a standalone eligibility condition for the program, so the rate went up to 83%. And then in 2013, the rate of folks with obesity was about 50%, and in 2017, with that eligibility change, it went up to 60%. And you can also look at other statistics, other sources of data as proxies for your population. So if you also look at the CDC data in 2010, the rate was about 36%. I think it's now closer to 40%. And then the Missouri BRFIS data spoke to about a prevalence of 30%. I think it's about 33-ish% now. And then we also looked at NCHS data on the pediatric population and the low-income population. And at the time, it was about 21.1% in boys and 19.3% in girls. I believe it's now sort of overall around 20%. So that's sort of the population, you know, that's the lay of the land that you're sort of working with as you get started. Let's see. All right, so, and folks have, you know, talked about this before. Why should you do anything about this, you know? So what can you gain? So in the literature, you can find that if you have a 1 percent point decrease in a hemoglobin A1C, you're going to see a 21% decrease in diabetes-related deaths, 14% decrease in heart attacks, and a 37% decrease in microvascular complications. 10% cholesterol reduction yields a 30% reduction in coronary heart disease. And if you do a 6-point reduction in blood pressure, you're going to see a 16% reduction in coronary heart disease and a 42% reduction in stroke. So if you can make these changes, you can have these impacts, you are doing those things of enhancing wellness and quality of life, reducing morbidity and mortality, and then impacting your costs. So when you're thinking about those impacts, you know, one of those things you are thinking about is what are the impacts of the disease, what's the burden of the disease financially, and then what are your potential savings if you develop an intervention. So, you know, in the literature you'll find that each Medicaid beneficiary with obesity on average costs about $1,000 more than a normal weight beneficiary, and through the work of the Children's Services Commission, you know, they predicted that Missouri will expend about $12 billion annually on obesity-related healthcare costs by 2013. So there is opportunity to have an impact. So our goals, when you're thinking about policy, what our considerations are, really, we want to follow evidence-based guidelines and standards. We try very hard not to create anything that's, you know, just sort of, we created that. So we want to make sure we're following best practice, what the evidence sort of, you know, shows that's beneficial. Again, want to positively impact morbidity, mortality, quality of life, maintain cost effectiveness. So we always have to be aware of what the budget is, what the financial impacts are, what we can do within what we have. We want to develop models for different methods of implementing a program. So we went through a lot of variations with the program that we're currently hopefully done drafting, but we're working on that. We want to assess the fiscal impact of the proposed the interventions and the conditions. And again, is what you're proposing cost neutral? Is it cost savings? The budget, if there's a budget impact, you're generally going to have to ask for appropriations for that. And then you want to assess the short and long-term impacts, clinical and fiscal. So folks are interested in what can we see, in 6 months or in a year, and what are you predicting 2-3 years out? So both on the clinical side and the fiscal side. And with the Health Home program, we're able to show that these interventions do impact both the clinical outcomes that we're looking at, and we've been able to bend the cost curve for some of those avoidable services. And of course, you always want to have a mechanism to evaluate. So you always want to come back, and people are always curious to see, what are the impacts of your program. And that helps really make the argument for sustainability and for continuing a program on. And then again, you want to attain approval or appropriations authority if you need to implement the policy change. So when you're talking about resources and reference points, again, we looked to other places to see what else is happening, what the best practice is, what the evidence is. So we looked to other national programs like Medicare, other state programs, national and state bodies of expertise. In this case, we're looking at the USPSTF recommendations, the AAP and others. When we were looking at early elective delivery, just as an example, we were looking at ACOG. So who can you refer to? And then, of course, the academic research world. And then national guidelines and literature. So as I mentioned, and Denise has mentioned already, talking about the guidelines from the USPSTF, and they have those for adults and children, as we all know. And so our process, as we were working internally, as I mentioned, we coalesced with the subcommittee with the Children's Services Commission, and we started working together. And that's been, again, a really fruitful process, I think, and helpful to us. We've included folks from pediatric hospitals and from the academic centers in the state. Went through a consensus building process and, picked people's brains on what they thought about different things. And then when, thinking through our modeling process, we went through identifying the services, the population, provider requirements. You have to identify a code set that you're looking at and identify costs and projected savings. So then you more specifically think about the services. Well, we're talking about intensive behavioral therapy, and then in the program that we're talking about, we are at a minimum trying to do what the USPSTF recommends. So we're looking at, and we're doing a little more than the minimum for the USPSTF. We're looking at about 29 hours for children in a year and 15 hours for adults in a year. And then there's some language about maintenance for some time after that. And then we're also including medical nutritional therapy. So that's still under discussion and hopefully moving through the internal review process within the department. And then with the population, you're looking at adults, BMI of 30 or greater, and children, it is 5 and older. And then age and gender specific BMI greater than or equal to 95%. And then the coding, we've identified a starter set of codes, and there's a little more discussion that we're having there. And then thinking about provider requirements, as you guys know, the Medicaid population is a complex population. We are currently looking at behavioral health specialists and then, of course, the registered dietitians for the medical nutritional therapy side of it. Because the Medicaid population is so complex and we are looking at this as a behavioral health intervention, we are focused primarily on the behavioral health specialists, though in the future, we could entertain other things as evidence might support that. And then you're talking about a certification requirement for your providers. Is there a state requirement? And this is new territory, and Denise and Sarah are sort of working on this. Is there a national certification process? We went through a similar process when we put together our asthma education and in-home environmental assessment program. There was a national certification available for the folks who would be providing those services, and there was work in the states around developing a state certification process as well, and that's underway. And then consider continuing education requirements, hours of work experience, mentoring relationships, et cetera. The workforce piece is critical, it's crucial, especially as this type of intervention is, it's new, but not new. So, we've been talking about it, but how do you develop that workforce and make sure when we roll out a program, there are people in place to provide the services? And that's pretty important to us as well. As we develop a program, you invest resources in, all kinds of systems work and really trying to build the infrastructure. So steps, and these aren't sequential, a lot of this happens in parallel. You define the issue and make sure you've got support. So there's a lot of support, I think, in the state around doing something around childhood obesity and adult obesity. For us, when we do our modeling, those two things travel together as sort of a packet program based on the modeling that we've done. And that is part of what you do, the modeling. And then you have look for the approval in the Appropriations Authority. We go through putting together a state plan. We do regulations. And then the systems work that I mentioned, provider enrollment systems work, provider recruitment, and really evaluating those outcomes as you loop back. And then, as a closing slide, I mentioned the Diabetes Prevention Program. That is another program that we're working on sort of in parallel right now to the Obesity Intensive Behavioral Therapy Program. So that's the quick summary of the work that we've been doing. It's been really a joy to work with the other folks in the state around this issue and the other departments and agencies. So when you're talking about systems level approaches, we very much focus on trying to take that systems level approach and putting things into that public health, population health context that we've all been talking about. So thank you for your attention. Thanks.